morning. Welcome to the ICOI webinar. My presentation is going to deal with immediate extraction replacements from single tooth to full arch. And I originally called this like the emergency implant because we have so many patients that call and say, I broke a front tooth. Chances are it was a root canal tooth, and they need to have something replaced due to their social obligation or work obligation. And so this is something that I've been doing for a lot of years. I co-authored this chapter in the book, Dental Implants, The Art and Science, and I co-authored the immediate replacement chapter. So what we're after is extracting the hopeless tooth, preserving the hard and soft tissue, and restoring the patient back to comfort, aesthetics, and certainly function, and showing that artificial devices can live in harmony with living tissues. And so we started with ICOI many years ago, along with its founders, Dr. Linkow, who was my mentor, and Dr. Weiss and Dr. Kenneth Judy has been very active in sustaining and forming ICOI as the great academy that it is today. And our early experiences were with the blade implant that you see on the right, and on real severe atrophic mandibles was the subperiosteal. We don't see as many edentulous patients today as we used to. We see more of the terminal teeth cases. So when I got into root forms, and then I started looking at extracted teeth, we see that the roots are tapered, and we were putting in parallel walled implants, which made it a little more difficult. So in 1993, I came up with a concept of a tapered implant, which you see here. And so this is kind of my history. My first implant, I thought was we should have an implant that we could treat it if there was some bone loss before it got into the threads. So my first development was 1986, was the Stereos, and we had the root forms and the blades. Root forms didn't come into real fruition until the 80s, when early 80s, when Dr. Brennemark introduced it from the company Nobel back in the early 80s. So these were some of the things I developed: osteotomes, which we'll talk about a little bit later in the presentation, and then the present is the Hahn tapered implant. One of the things that we kept was the machine collar, and to help prevent peri-implantitis. So the rationale for tapered implants is it increased primary stability, because basically we look at it as a wedge. It's easier to replace, to place in anatomically constricted areas in a more favorable position, because the area that the tooth came out of is not square, it's generally tapered. And we can use a wider implant, which is important at the top, what we call the prosthetic table, the cervical, and it helps reduce force during functions. The wider the top of the implant is, the more it can withstand more stress. So just to look at the implant that my latest one is, we have more aggressive threading, and we kept the machine collar. So when we look at the history of peri-implantitis from 1985 to 2005, peri-implantitis was mostly absent. We didn't start to see it until we had implants with rough surfaces at the collar. So now let's talk about extracting or not extracting. And that is the question. Don't save compromised teeth. These are things that I've learned over the years. Consideration periodontally has that tooth lost more than a third of the bone. Endo consideration is the tooth restorable? Can it be treated endodontically with a good prognosis? Caries, as it carries severe enough that it no longer can be restored, or if it is, it doesn't have a good prognosis. And the immediate placement is basically an alternative to crown lengthening. So because we're going to be preserving bone and crown lengthening, you're reducing the bone height. So here's a typical case where we see the cervical area here, severe caries. And so the tooth was removed and then an implant placed, and then after integration restored. So basically we look at the implant as a much better option. It's stronger, it's not going to break, and we can get a nice aesthetic result as well as functional. So this is typical here. Extract, we prepare the site, which we'll get into. We place the implant. We want to achieve at least 35 to 45 Newton stability. And if there's space of more than 2 millimeters, basically at the buccal surface, the facial surface, then we can graft that at the same time. If we achieve that primary stability, then we can place a temporary abutment or whatever and make a temporary restoration and make sure it's out of occlusion. So here's a typical case. You see the x-ray, what we're talking about, poor prognosis with the endo treatment that's been done previously. So we remove the tooth, place the implant. This is screw retained. You see the screw opening before we've sealed it, and then we place the ceramic crown. So one of the other advantages of immediate placement is we can get it in a more favorable position and a better crown root ratio, as we see here. This is much better. We're able to place a 13 to 16 millimeter length implant in a much better position, which makes it more favorable for the restoration. And here you see another example of what we just talked about. And again, we have something that looks like what nature gave us originally. And so we're restoring the patient back to function, comfort, and aesthetics. So this patient has a history of osteoporosis, so we didn't want to immediate load with a temporary. And I tried to place an implant as long as possible. And here the apex is engaging the inferior cortical bone. And as we go close to the sinus, the bone becomes more dense. So we're not going to do immediate loading. And so we place a healing abutment and then a little one-tooth flipper. But you see, this tooth was vertically fractured. And we want to get those out as soon as possible because vertical fractures will lose bone overnight. So we have kits today. We have a standard surgical kit and guided kits. Now, I like the guided drills because the hubs are longer for the guides. So we can get into where we have constricted areas to keep the handpiece from hitting the adjacent teeth. And but we don't have enough room to use a drill extension. So these drills can be very useful. And we want to have a selection of implants that will take care of most clinical situations. So narrow, constricted areas, congenitally missing teeth, we have a 3.0 implant, which tapers to 2.2. And then for molars and in wide ridges, we have a 7.0 implant. So here's just an example of some treatments. Here's two congenitally missing laterals that were placed, the 3.0 implants, and then the final restoration, ceramic abutment, ceramic crowns. So again, restoring the patient to form and function. And there's another example. Again, I try to get as close to the inferior wall of the sinus because the bone is more dense there. We increase stability. Now, here's an immediate molar. Now, we cannot always rely on a CT scan. So some of the studies show that a CT scan in the posterior mandible can be off by 10%. So after we extracted this tooth that was fractured, we took out the mesial distal root, prepared the interseptal socket, and placed an 8mm 7x8 length diameter implant, and then made a fixed crown on a fixed abutment. So we look at, again, the CT scan, which we can use. Now, this isn't that patient, but just gives you an idea. And so here we used a fixed abutment cement crown. I did this back in 2015. Today, I would have done screw retain. Posterior, I prefer screw retain. So here's some different examples of different abutments for the system that I developed. And again, we see the color coding, which helps determine what parts and pieces are fit. I was the first to come up with that when I developed a replace for Noble Biocare. So the screw retained is easier to retrieve. Fixed can be removed if you do use provisional cement. Screw retained access requires maintenance. Not a lot. Just make sure you put cotton in there, and then you can put composite. The screw retained position is more critical. So if you are going to do screw retained, you want to keep it in harmony with the opposing dentition. And with a fixed abutment, the anatomy is not disturbed. And so it might provide more favorable aesthetic. So I prefer fixed abutments for the anterior, and the posterior, I prefer screw retained. So abutment retained, we need 8mm interocclusal space, and screw retained, we can do it with 6mm. So what is the criteria for success? No pain. Pain can be a signal that there's something going on, that there's some deintegration taking place, forming a fibrous connective tissue. There should be no mobility. And the tissue, the soft tissue is a barometer. If it's red, inflamed, bleeding easily, there's something wrong. So you need to take an x-ray. Now, if there's no pain and the tissue is pink and stippled, don't probe it. You don't need to. It's fine. So that's why I say the soft tissue is a barometer. So there should be no crestal bone loss after 1 year of function of 1 and 1.5 to 2mm. So we look at all the studies. I've been in a few of them myself, and the statistics come out pretty much the same. An immediate replacement compared to delayed replacement. So we're looking at still 97, 98, sometimes a little bit higher success rates after a few years in function. So this is my own study that was published in that book that I co-authored, the chapter. So you can see as we got into the tapered, more anatomically implants, our statistics on immediate placement came up, but also there's an experience and learning curve. So you can't always go by studies. So why do this? Why doing immediate replacement? Well, we have aesthetic demands. As I said, the patient has social obligations, work obligations. If it's in a tooth that's been problemed in the aesthetic zone, premolar to premolar, then that's the case that most people are going to want to treat. So if you do that, a patient can come in. That doesn't take a long time. It doesn't take even more than an hour. Remove the tooth, place the implant, and temporary abutment and provisional crown. And the patient's very happy, and they generally will tell their friends, family. So it's a good practice builder. So what about delayed extraction replacement? Well, we'll show some examples of insufficient bone volume for primary stability. In that case, we're going to graft and then place the implant 5 or 6 months later. Delayed placement if there is active infection or purulent exudate. We don't want to place that in an area of infection. So what do we do there? So we extract, remove all the granulation, inflammatory tissue, and prescribe antibiotics for 10 days. And then we can go back and place the implant a week or two later. So we want to play it on the safe side. So what I've done, again, according to my experience, classified the sockets, 1, 2, and 3. And it's not only for my own benefit, but for teaching purposes. So I do a number of one-day hands-on immediate replacement courses. So I wanted to have a basis to help the participants to understand the treatment, the subsequent treatment of the different classifications. So we said, class 1, all the walls are intact. We take the tooth out and we check all the walls of the socket, and they're all intact, no fenestrations. Class 2, there's a fenestration somewhere, whether it be in the middle of the socket or apex. But there's still enough bone for primary stability. Class 3, labial or buccal bone wall is absent. So we'll talk about treatment in those 3 different classifications. So the first thing we're going to do is, once we extract the tooth, is we go in with a periocurator and drag it around each of the walls. So here I've dragged it against the facial wall, and we see there's a large fenestration. So maybe we decided to graft and then place a flipper or something like that. So here's an example of class 1. This is a full arch case, but all the sockets, all the walls were intact. This was a patient that had severe caries, that the teeth were not restorable. So there's an example of class 2, where we have a large fenestration, but we have crustal and we have enough bone for primary stability. And then here's there's an example of treatment of a class 2, where we prepare it as if that fenestration wasn't there. Then we can place our graft material, and as we place the implant in, it will force the excess graft material through the facial defect, and then we can cover that with a putty-like material, alloplastic material. The first material is a cortical cancellous particulate, and the other is more of a collagen putty, serving as a membrane. Now here's an example of class 3, where we still have bone mesial, distal, and palatal, but there's not enough, there's nothing on the labial. Now we do have some apical bone, and so this can still be done immediately. So we keep the implant against the palatal wall, away from the thin facial areas, and then we can place our graft materials that I just described. And then we want to be sure that we've achieved our 35 to 45 Newton stability at the time of placement. So I'm just going to describe this fairly quickly, because you'll see in the example photos what we're talking about. So after we've decided what classification a socket is, after we remove the tooth, We then can start with our first drills, depending on the length and diameters of the drills of the implant we decide to place. So we can place the drill to the apex and then slide it 2 millimeters to the palatal. So we keep it again away from the facial wall. That's the main thing, because the facial wall is very thin and doesn't have much blood supply. It only gets it from the periosteum. So we want to keep it, there's more bone generally palatal, which we can see in this illustration here. You see a tooth that's right up against the buccal plate. It works because the tooth has a periodontal membrane. It has blood supply, but an implant does not. So we want to keep it away from the facial plate so we can have some blood supply in that area. Now, if it's more than 2 millimeters, then we can also put some graft material. So here's an example. We go in with the first, what I call the pilot drill, and then we've gone 2 millimeters lingual to the apex, like we're going to show here. So you see on the left photo that there's more bone on the palatal side than the facial side. So this is ideal. And so we can get these in. My experience is it maintains itself like this, healthy tissue stability and bone stability for many, many years. So here's another example of that. And then the reason I spent some time is basically to stress that we do not want to engage the facial bone. So again, an error, and especially people that are starting in this, is placing it too far facial. Now, some people prefer to do these guided. Well, most of the time that I've seen in my practice is it's an emergency implant, and you don't have time to make the guides and do all of this. The patient wants some instant gratification. So if you follow the technique that I've been showing, where you go to the apex and slide it to the palatal, and you'll be in a good position. So as far as length and diameter, if you take out the root, extracted root, you can make measurements and then decide how long you want to go, depending on vital structures, such as the metal foramen and the sinuses, and the neurovascular bundle, the inferior alveolar canal. So there you can make your adjustments and whatever. Now, patients that have internal external resorption, you do want to get those teeth out as soon as possible. And generally the roots are ankylosed, because they will continue to lose bone. And if there's an aesthetic area, you want to be able to maintain as much of that bone as possible. And you want to be able to preserve interproximal bone, because that supports papilla. So what is our considerations? Well, certainly available bone and available soft tissue, the mesial distal space at the crests, so we're not going to be too close to the adjacent tooth, and the position of adjacent tooth roots. Are they angled in to the space where you're going to be placing the implant? And so we have to consider the implant angle. And we like to have the gingival margin of the final restoration of the implant in harmony with the adjacent teeth. So we have some other, besides our CT scans, we have other instruments available. This is a bone caliper I've used for a number of years. And so we can see the width of the ridges. And then we have also what I call a measuring stick. So we can see mesial distal available areas. And we like to see this good keratinized tissue. Now, this was a case where it was previously grafted, and now we're ready to place the implant. And there was insufficient bone volume to do an immediate. So again, this describes what we're talking about. Now, as said before, the advantage of a tapered implant is bone is not square. If you section the mandible and maxilla, there's a series of triangles. So we have the subnasal fossa, the digastric fossa in the mandible, the submandibular fossa, the buccal fossa in the posterior maxilla. And so again, we like to have the implant 2 millimeters away from adjacent teeth. And we'd like to have 2 to 3 millimeters of soft tissue margin for the abutment. So whenever I place an implant, my first thought is prosthetics. What's it going to look like? What am I giving the technician? So here again is another illustration of keeping the implant against the palatal wall, which is thicker and denser than the labial wall. Now, the angulation affects prosthetics. So whatever we do surgically, sooner or later down the line will affect what you're doing prosthetically. So you see, this is not favorable. At least I don't think so. So we look at, again, keeping the implant away from the facial bone. And you want to be sure also that you're root planing the adjacent teeth to get any soft tissue calculus, any deposit off the adjacent teeth. So when you enter in with your first drill, you don't incorporate any of those toxins or anything. The other thing is handling the soft tissue. Now we know that the palatal side, the soft tissue is thicker and denser, and I call it the masculatory tissue. So I try to make the incision on the lingual aspect of the crest of the ridge, and then bring that tissue to the buccal, and then place the implant where we've measured and exposed the bone. So when we do the final restoration, we have nice keratinized tissue in harmony with the adjacent teeth. Now, what about a perforation? And it's happened to all of us. So what we could do is just redirect the drill and then place some graft material, hydrate some particulate graft material, and then as you place the implant, you don't need to use a membrane. Now, I've just done this on a model. You don't flap it like this. You don't need to cut the tissue away or anything. You've just felt it when you were going in with your drill, and then all of a sudden your drill just goes deep. So here's an example, just hydrating some particulate, and then as we put it in, you see it forces it through. Now, in most cases, you'll have the soft tissue with the periosteum on the buccal, so it's fine. Now, we look at also the quality of bone. Now, wide ridges are softer bone. So generally, these are cases that you can use osteotomes to compact the bone. There's 3 different uses of osteotomes. Now, we see this when we colorize the scan, and you see the blue. That means there's a lot of blood supply there. So it's softer. There's not a lot of trabeculation. But as we go closer to the sinus, again, you can see it's more dense. So here we'll just use 1 drill. And we're going to probably do this flapless if it's a wide ridge. So flapless, we have adequate height and width of bone, adequate keratinized tissue, at least 5 millimeters. There's no severe undercuts. Basically, there's no surprises. And you can use the bone caliper that I showed before. So here you can see, again, it's a wide ridge. So wide ridges are softer bone. And here we can just go in with the first drill, and going slowly, you can go right up to the sinus wall. And now, what are the uses of osteotomes? Well, one is compact bone. That's what we're going to do in this case here. The other is expand bone. So generally you'll go in with one drill and then start with the small diameter osteotomes. And I suggest that you sedate the patient either IV or orally, because you're going to have to use a mallet where you're going to drive the osteotome slowly to place to the depth that you want and expand the bone. This bone is viscoelastic, but you need to have at least 3 millimeters of buccolingual bone to start with. And then sinus floor cortical elevation, where you go up to the sinus floor, and with the final osteotomes, you bump that with a mallet. Basically, you're cracking that cortical floor, and then you can place some of the particulate graft. And then as you place the implant, which is a little longer, for instance, if you've gone to a 10 millimeter length and you want to put in 11.5 to 13, you would then, after you put your graft material, then place that implant, and that'll push that graft material up into the sinus. So the purpose is to gain at least 3 millimeters to 4 millimeters of height of bone. So you prove crown root ratio. It's a case, a technique, basically, that we've been doing for years and taught to me by Dr. Tatum. So these are some examples. This is an example of the osteotomes that I use. We start with a small diameter and going up, there's a 2 millimeter, and then it goes to 3.5 to 4.3, and then up to 5. So here you can see in the X-ray the position of the osteotome. It's compacting bone. So there you see we have some primary stability, and it's protected by the adjacent teeth, so we can place a healing abutment. So then you see after 4 or 5 months, now we're going to let this heal a little bit longer so bone can reform. And here you can see that the density is much improved. So we have good stability. So it's just removing the healing abutment, doing a transfer impression, and then the final restoration. So here's just, again, using the bone caliper, we can measure if we're going to do a bone expansion, and we can measure the buccolingual with the bone. So we want to have, if we're considering a bone expansion, rather than doing an onlay graft, we want to have at least 3 millimeters of bone, buccolingual. So here, we try to keep, for most of these, I want to keep the periosteum as much as possible on the bone, because when we do a bone expansion, we're basically going to create microfractures of the buccal plate. And if we keep the periosteum on the bone, then that will allow it to readapt and heal nicely. It's like the laminate on the windshield of your car. If you get a broken window, the pieces of glass generally stay because that laminate, basically, I compare it to the periosteum. Excuse me. So here's a couple of examples. Now, we just exposed the crest, just the buccolingual crest. And here, we've just used one drill, a 2 millimeter twist drill. And then I took the 3.0 implant and then self-tapped it. And we go in and out, in and out. And we're basically expanding the bone somewhat with the implant itself. And again, we try to keep it somewhat as much as we can against the palatal. So again, you see that we have, since we generally achieve good primary stability, then we can place a provisional crown out of function, make sure it's out of function in all excursions, and then go through our normal restorative process after 3-4 months. So you see again, these are some constricted areas, but I try to go as long as possible. These are 16 millimeter length 3.0 implants, again, going up right up to the cortical wall of the sinus. Now, when you go in with your first drill, again, you can take an x-ray to check that you're in a position that you want, because it's like doing endo. If you're not happy with that position, you can change it. So anything you've done, there's still blood supply and it'll heal. If you happen to touch the adjacent tooth, just redirect it. So here's an example of a couple of them again. So we can get a nice result. Notice the tissue, it's pink and stippled. We're in harmony with the adjacent teeth for what it should be. These are lateral incisors. And here you see, again, using the osteotome and just making an incision so we can see the buccolingual line. And then here you can actually see how the bone was bulged somewhat, a little bit on this case here. You can see the architecture. So it's just placing temporary abutment in suture mesodistal, because we're trying to preserve as much of the soft tissue as possible. So again, we have this patient congenitally missing lateral incisors. We in place with 2 3.0 Hahn implants with immediate provisional crowns, final restorations of 2 bruxal crowns. So I think we got a very happy patient here, especially the parents were very happy. So here's a case where there's insufficient bone volume. This patient had fallen and apparently bumped their mouth or something, I don't know, and didn't know it. So they had a vertical fracture, and so you see the amount of bone loss. So we didn't want to take a chance on doing immediate placement. We would have to place a very large diameter implant, which wouldn't fit in very nice with the adjacent teeth. So the tooth was removed. We cleaned everything real good. And then we've taken our mineralized cortical cancellous bone and then put that in. And then we use, I prefer to use the osteoplug over that. So we have a combination of the mineralized cortical bone and then over that. This is the particle bone, particulate bone, is raptus, and it's available from a couple of different sources. And I prefer to use also the vicral suturing. So here we see the raptus placed, and then over that, the osteoplug, and that's the x-ray on the lower right. You see the after the graft. And then we let that heal 5 or 6 months so that organizes. And then we can go ahead and place the implant. Then after that integrates, do a transfer. I use closed tray impressions. That's what I'm used to. And then final restoration. Now, in the meantime, we made a 1-tooth flipper, which you see on the left side. The photography, the color was better. I don't know why the photography, when I took the picture, why it came out differently, but we had a good result. The patient was happy. So here's a patient. We evaluated the teeth themselves. She has a history of not doing well with crowns, with recurrent caries, and she's had other implants which are very happy with. So talking it over with the patient, she said, let's just take those out and do implants. So that's what we did, 2 immediate implants, 2 temporary abutments, and acrylic temporaries out of occlusion. And that's the day we did it. It didn't take a long time. And so the patient walked out with temporary out of occlusion. And then after 3-4 months, and we went through our restorative process, transfers, and then bucks or crowns. So again, restoring the patient back to comfort, function, and aesthetics. So this patient is a pharmaceutical rep, had to make calls that afternoon. And she came in with a crown in her hand, asked if I could re-cement it. And as you see there, the root was mush, very soft. I told her that it's not going to work. And she said, oh no, what am I going to do? And I gave her the option that we could have to take an impression, but I couldn't get a tooth maybe that day, but next day, or do an immediate implant and make a temporary. And that's what she chose. So here is an example on a model that we use to teach. Now, the reason we're using a thread former, and I just want to bring that to attention here, is if you have one that has really, really dense bone, and you're using an implant that does not have aggressive threads, you may have to tap the palatal wall because you don't want the palatal wall to muscle the implant and push it against the facial as you're putting it in. So that's, you see on the upper left, the 2 dots, one at the apex and then one where we've slid, move the drill 1 to 2 millimeters palatal, generate 2 millimeters. So here's the pharmaceutical rep. She had the crown so I could use it. I put on a temporary abutment, made sure it was out of occlusion, and we just purse stringed the suture and making sure we preserve the papilla. And then in 10 days, she came back for suture removal. And then we were able, and after 3 months, to do the final restoration. These are just some examples. The one on the left was the temporary abutment that we used. And we can prepare these. I use a 558 cross-cut Fisher burr. I use a sharp burr on just one abutment and then throw it away. So we have a whole plethora of abutments, most systems do, that you can choose. I prefer to do all custom abutments on final restorations. As you see, the use of the 558 crosscut Fisher burr, and then the temporary. So these are examples of, I'm sure, teeth that you see in your practice. Now, how do we get these teeth out? Because some of them are very difficult because they're soft, they're broken. So I use a 700 XXL Fisher burr. I can't be without this burr. So we go on the root, stay on the root, work our way to the alveolar process and create a groove, a channel that we can go in with these sharp elevators and get the root out. Here's one that just didn't have enough bone value. We had to graft. We went back in 5 months and placed the implant. And then this is 6 years follow-up. So here's an example of class 2. So we talked about before. So we're going to stay against the palatal wall. We're going to go apex, apical if we have bone, 2 millimeters apical to the fenestration, and then placed our graft, place the implant, and then we can use our osteogen plug over that as the membrane. I'm not a big fan of these collagen membranes that you have to tack. So here again is an example, placing the abutment and then preparing it with a 558 and suture, and then the temporary. And you can see it's a little shorter, so you want to be sure it's out of occlusion. And then 4 months post-op, you see the healing, and more importantly, you see how it's preserved the interproximal bone, which supports papilla. Now, this is something that's available called the physics forceps, but you have to be careful with it. You have to just use it just to get the tooth just to break loose, just to loosen. And you need to keep what we call a bumper against the buccal plate, so you don't fracture the buccal plate. So you just do it so you just get it a little bit loose and then deliver it with regular forceps. So this is my surgical bone grafting kit that, again, it's the one I use. I keep my favorite instruments in it. This is available through Glidewell. So if we want to totally graft the socket, we do a 4-point closure, and then we go back in 6 months, and we can see that using that combination, we have real bone. So we've done histology on an example, and we show that in 13 weeks, we have natural bone. So when you have a buccal fracture, this tooth was split. They lose, like I said, bone overnight. So here, there was no bone volume at all. The buccal was totally gone. So I grafted what I previously just showed with our combination of the 4-point suture closer, and then we have bone. Then we wound up placing a 4-3 by 11.5. And you see on the lower right slide, the tissue is pink, and you know, so that's healthy. Now, again, here we go and showing the position of the first drill. You see it's slightly parallel to the adjacent teeth. Again, you can make your measurements when you extract the root and then decide what you're going to do. Here, this patient came in and already had a flipper. Her cousin's a dentist. So he had made a flipper because the tooth was fractured. So I just put on a 3mm healing abutment and used the flipper. We had a little more than 2 millimeters on the facial, so we just took some particulate and put it there. And her cousin made that flipper on the right. And then afterwards, we did our transfer, made a ceramic abutment, and then the final restoration. Again, we see the X-ray on the right, nice interproximal bone. Here's another patient, a fractured lower anterior. So we put in a 3.0 by 16, had a little 1-tooth snap-on flipper, and then afterwards, the final restoration. This is a 2-year follow-up. So this, again, would be a class 2, had a large buccal fenestration. This is a wife of a dentist friend of ours. And so we extracted the tooth, placed a 16 3.5. You can see again up against the cortical bone of the sinus, a temporary abutment. Used her existing crown. We reformed it with some composite. And then 3-4 months later, took the transfer, ceramic abutment, ceramic crown. And you see the nice health of the soft tissue and the gingival harmony. There's another patient that called in the morning, was going on a cruise the next day, so got him in at lunch as emergency. She's had other implants that I've placed, so she called and said, I need an implant. So here we, again, place the temporary abutment, prepare it, and then I reformed her crown that she had. She had a PFM, and then they could go on their cruise, and then some months later, we were able to take the impression. And these are just some examples, what we're just showing. Now, I want to share this with you. Absence, this is class 3, absence of buccal plate. So we make an oblique incision and then an incision mesial distal on the palatal side. And then I open it up like a book. I try to minimize my vertical incisions. So like this, I call it the book approach. And then this patient, daughter was getting married, insisted that I do an immediate temporary. So I didn't know if I could. I told her, but I wouldn't make promises, but I'd try. So here we see, again, staying against the palatal wall, then self-tapping the implant. And you see the oblique incision is away from the graft site. So we just have a mesial distal incision and then a vertical on the 45 oblique. So we protect the graft. And then I used her existing crown and then reformed it and made sure it was out of occlusion. Then 5 months, you see the healing and then the final restoration. So you see, final restoration is tooth number 9. And you see that nice pink stippled tissue and gingival harmony. So here's a patient I inherited. An orthodontist friend sent it over. Somebody placed an implant way too far buccal. Could not restore it, so I had to remove it. Took buccal bone and treated it as a class 3 socket, and then placed an implant against the palatal bone, grafted it just as I showed in the previous slide and in the final restoration on the right. Here again, just some examples of class 2 and finished restoration, temporary, final restoration. So here's when we're talking about gingival harmony. So this patient is a retired dentist. That was a good referral for our practice. And he called and he said, Jack, I got a tooth that's loose. I'm going to Florida tomorrow. And I said, well, come in lunchtime and we'll see what we can do. So he came in. He had bone apical to the buccal fenestration, but the tooth was loose. It was a root canal tooth that fractured again. So you can see we used our putty, our particulate, and then the osteogen plug putty over that, prepared that, and then I just made a temporary by hand. It wasn't beautiful, but it served a purpose. And then he goes to Florida for the winter. When he came back, we then did the final restoration, made it screw retained because I had the implant position palatal enough. That little blue dot that you see above that was from me, my probe. I got a little over aggressive with the probe, but that went away. Now this patient came in and had a lingually locked lateral, and I told her that she should consider ortho. And she said, no, you're the third person that told me that. I'm not going to do it. I'll find somebody to do it. So I thought maybe this would be an interesting case. And so I removed the tooth and then I reshaped the buccal plate to create, again, what I call gingival harmony, thinking about the final restoration. So that's what we did. We took it out, did an alveoplasty, and then placed the in nice long, nice good implant. And then you see this worked in a nice position. So I called it instant orthodontics. Some people may not agree with that, but she was going to go somewhere. And I thought, well, she might as well have it done by somebody that's experienced. So here's just another example. I know you've had these teeth in your practice, unrestorable, and come out in pieces. So again, we placed our combination and did the 4-point closure and used our Vicol suture, and then went in 5-6 months later. If this one was 4 months, and then we can place a nice wide implant. And then final restoration. There we go. So again, following these techniques. So what about failure? Remove the implant curette, remove any soft the granulation tissue. If all the socket walls are present, the next larger diameter may be used as self-tap to place. If the walls are not intact, then graft and place another one 5 or 6 months later. You want to, again, play it on the safe side. So, it's a fact that all of us are going to have a failure sooner or later. It's just you don't want to make another failure happen. So, again, don't place graft material in the presence of infection because the pH is too acidic. So, take it out, clean it good, put the patient on antibiotics for at least 5 days. I prefer 2 weeks, 10 days to 2 weeks to make sure. And then you can reappoint the patient. Now, what are the 2 biggest causes of failure? One, occlusion, hyperocclusion. We want to make sure that it's not hyperoccluded. Not enough implants for the desired prosthesis. So we call it's overload again. So here's my pilot checklist. What is the desired prosthesis? Is it fixed or removable? Removable is not as stressful. What is the quality of bone? Where is it? Posterior maxilla or anterior mandible? What is the opposing dentition? Is it natural teeth or a denture? Whatever. How strong is the muscles? How strong is that patient? So these are things we consider. Also, you want to know the end before you start. Now, this patient had too much bone. It was a dentulous. So we know we had to do, at the time of surgery, an alveolectomy. So you want to be able to plan and know. Over-retain teeth. Don't keep teeth too long. So these patients, maybe financially or whatever, but finally, family or work has to say, you got to do something. So this is the same patient here on the left side, as you saw there. So we've done a number of these. I basically market the terminal teeth patient. So here we see where we placed. I prefer to do 6 on the maxilla. If we're going to do all on 4, we'll do 4 on the mandible, but 6 on the maxilla. And here you can see the final Bruxer restoration. We did this was one of the first ones we did in 2014. And that's her smile. You can see how we try to place the implant as posterior as we can without infringing on the neurovascular bundle. On the upper left, you can see the mental foramen, and we teach the students how to find that and try to. My courses are generally teaching basic freehand before they get into guided. So we try to minimize the cantilevers, and you can see some of these are life-changing. This patient had stomach cancer and had ruined most of her teeth, very severe caries. Then she went through the cure rate, and we were able to place the implants and restore. And this was a real drastic case. Actually, I showed this. There was an article in the newspaper, and Jay Leno picked that up when he was doing newspaper stuff. And he mentioned my name in Cincinnati, Ohio. And he said that she must be on something. And she was. She was a recovering drug addict. And her grandmother said, now you've got to fix yourself up. So her grandmother paid for all this. So we have something that's very life-changing. So what have I learned when we're talking about immediate placement, emergency implants from single tooth to full arch? Keep the implant from contacting the buccal or facial at the time of placement. Do screw retain restorations when possible. Select patients with positive attitude. Use experienced high-quality laboratory. So again, don't save compromised teeth. Know how much bone is available. Treatment plan for the desired prosthesis. avoid overloading numbers of implants and occlusion. Avoid tightening the implant over 50 newtons. Over tightening, you can cause compression necrosis. So we want to keep it basically 35 to 50. Avoid placing implants too close to one another. We need to think about blood supply, bone. Keep implant away from contacting the buccal or facial bone at the time of placement. Do screw retained again, restorations when possible. And we just said select, which is very important, patients that have a positive attitude. So everything I do goes to Gladwell Laboratory. I've been using them since 2012. They're experienced implant lab. And so that's what we think about. I know the technicians that we work with, they know me, and they know what we desire. So that's the laboratory itself. And then my team is on the left is my surgical prosthetic assistant, the guy in the blue shirt's the patient, and me, and my treatment coordinator, Gail. Barb on the left has been with me 36 years, and Gail's been with me 46. And then my son, Jeff, he's the one that did our website, our Facebook page. And so the future of implant dentistry is brighter than ever. We have all the new things with the scanning and guided surgeries, now even robotic surgery coming, but we still need to know the basics. So ICOI has a big program coming up, I think next week, good lectures. And I have a course in Louisville, Kentucky at Glidewell Training Center, where I'm showing exactly what we showed on this webinar. It's a hands-on one day in Louisville, Kentucky, October 20th. So again, here's my contact information and my email and my text number. You can send me questions or x-rays. And since I'm hearing impaired, I learned to live through email and text. So, but I get to them right away. So thank you for signing on, and good luck in the future.